too much maybe for Switzerland today, but
Okay, I will start with the broadcast in 1 minute. And
so Francesco, just to briefly tell you again, I have to leave a bit earlier at the end. I have another meeting.
Yeah,
so
you have the Brazilian Congress, I know.
Yeah.
So that's why you are the first to speak.
Yeah. Thank you very much.
Yeah, no worry. My pleasure. And so after the feel free to leave me.
Okay, ladies and gentlemen, good evening. I am Ala Al-Banasuri. I am the chief of the cornea and refractive surgery at the Maghrabi Hospital in Jeddah. And I have the pleasure and honor to moderate this symposium. And I'd like to take the opportunity to thank CSO, especially the R&D department in CSO, for making this gathering possible. And this is a great addition to the educational series that CSO have been doing for the last few months. And this evening we have a group of wonderful presenters. Without any due delay, we're going to start with the first presentation from Dr. Emilio Torres-Netto. Emilio works at the University of Zurich. He's an accomplished cornea, cataract, and refractive surgeon. Emilio has lots of publications focused mainly on cornea, keratoconus, cross-linking, and biomechanical properties of the cornea. And Emilio is going to teach us the OCT-based corneal topography as a new era in diagnostic. Emilio, please.
Thank you, Ala, for the very kind introduction. Let me share my screen here. So can you see the screen right now?
Yeah, wonderful picture.
Okay, thank you very much. So first, I'd like to thank CSO for organizing this very interesting webinar. It's such a pleasure to participate with this great team. Thank you very much. So let's go to our topic, OCT-based corneal tomography, a new era in the diagnostics. So these images here show our current equipment at ELSA Institute here in Zurich to evaluate the anterior chamber. So we have a wide range of anterior segment tomography and other devices as well. And although I don't have any commercial interest at all, I have to say that this new device, which we've had since last year, has really been a game changer for us in some cases. So this is a spectral domain OCT combined with placido disc topography. So we have here the two technologies working together. And of course, this brings the biggest additive benefit of the OCT here. And we all know for a long time, but here are some advantages of OCT technology. And I would say the main one would be the image quality. So when we see a OCT image, we can clearly see it is from a OCT. We can clearly define this. So the quality is something that brings us attention. But especially for cornea, the analysis of structures that normally are deeper in the cornea used to be better seen or better measured with OCT. So we are also used to check the pachymetry or the demarcation line in cross-linking, for example. We usually measure it with OCT. So we can see deeper structures, and especially it is less affected by the scattering, so opacities are less affected. And finally, another, now not on this deeper on the corner, but on the surface, would be the epithelial map. So this is a quite new additive tool in refractive assessment, I would say. So from now on, I will show here some cases in which we used OCT and it was decisive. So instead of speaking, I will show you some cases we had. So this first case was a patient with keratoglobus. So he had a very intense protrusion, as you can see here. And there is not only a diffuse thinning, but also some opacities. And when we see the Scheimpflug images, these were on the right, on the left inferior inside, we can see how those opacities limit the ability to view the endothelial level or more posterior in the cornea. And of course, this limitation of Scheimpflug also reflects the ability that we have to estimate pachymetry or the thickness of the cornea. So you can see the thickness, corneal thickness profile here, quite homogeneous from the half inferior of the cornea, and we questioned if this was really the case of our patient. But then on the other hand, here we can see already measurements with OCT and placido technology, and that was much closer to what we found clinically. So the left inferior images show now the corneal thickness profile of this cornea, and basically these better results and these better measurements would be possible, or they are possible, due to an acquisition of images that have less noise than Scheimpflug. And here you can see very well how we see the back surface very clearly here. And of course, this information can be very important for many reasons, but in our case was important for surgical planning. So advanced cases where DALC also would be indicated, this image can help to program, to plan the surgery. But here in this specific case, we did a cross-linking with our SUP 400 protocol, and it was very useful to estimate the thickness pre-operatively correctly. And here is the pre-operative progression. So before cross-linking, just to illustrate this case, and a stability more than 2 years after individualized cross-linking. So this is not a subject, but just to show you how we use this technology in our favor to really see almost limbo to limbo, both sides with high resolution in a keratoglobus patient. A second case that OCT provided us with a very interesting tool was regarding epithelial maps. So this is a case of map dot fingerprint dystrophy. You can see superior on the placido discs there are some irregularities. And if you notice the resolution, the image show very well the epithelial lesions. When we do it a bit closer, we can see even better. And now this is another interesting tool that MS39 brings us. It's what it call anamorphic images. So basically it makes the anterior surface straight, and we here can see the cornea in a way that we were not used to see, but we can see, of course, a very high resolution. If you note, we can see even the Bowman layer. So the Bowman layer are those two layers just above the endothelial. So these can be very helpful for identifying, for example, patients after PRK. So if you're not sure if the patient had or not PRK before, we could observe these two lines. So the presence of Bowman, of course, would say that the patient did not have PRK. But here, our patient, and again, we could see that the lesion of that patient were just at the endothelial. So this image brings us a new toy, let's say. And not just that, but also this steep area that the patient had coincides or there corresponds exactly where the epithelial thickening area was. So in this case, specifically, the epithelium was removed. This here was with alcohol. And then right after, a PTK of 15 micra was done. And here, just after, right after the surgery, you can see the epithelium was removed already, and we can see how the epithelial surface was improved, and this was reflected by the sagittal anterior topography, and this was just after the procedure. But perhaps this is one of the most interesting cases we had, as we could observe, which actually changed the treatment management because of the OCT technology. So a patient came with mixed astigmatism for refractive surgery. Here you can see the preoperative tomography. So she had mixed astigmatism, and that was ablation profile that was planned and performed. And the patient, the surgery had no issues. The post-op was unremarkable. But then a year later, the patient returned, and she was complaining about low visual acuity, and we could see here in the periphery the haze. So this is an OCT image. On the right corner, we can see the densitometry from a Scheibflug device. And here again, the tool that MS39 provides us, we could see dotted in the yellow lines, the epithelium, and right above in the peripheral area where the ablation was performed, we could see there the haze. And this was a year after PRK, so on the left, the anterior curvature, and from Scheibflug, and on the right is the densitometry. So you can see that exactly where the haze was, we had the flattening. And again, another Scheibflug images now from Sirius. But for our surprise, just come back here, you can see how Scheibflug measure the topography. So it was a bit irregular at the center. But then for our surprise, this is the OCT-based topography. And what we could see was a very regular central astigmatism, actually. So we had now different technologies bring us different results. And in this specific case, we knew that for Scheibflug haze was or is has a limitation. So we consider this exam from OCT the real or the most close from what we thought. So this was the case where the OCT changed our management. Actually, there were two surgical options that we thought about, and those options were the dependent on the pattern of the ocular surface. So we would perform a PTK if we had a regular astigmatism or a regular topography, while we could have done a wave-guided PRK, for example, for irregular anterior surface. So this case, PTK was preferred from the reasons I told you, because we had a regular topography on OCT, and here in the post-op period, as you can see, the haze improved, and also visual acuity show us now a more regular surface. So this could be achieved, and this was an important case for us that we realized OCT can be very helpful. And lastly, here I will show two cases where the OCT can be very helpful in the screening of keratoconus. So here, a patient who came because he had had previous diagnosis of keratoconus for other colleague. So he came for a second option, and we observed a cornea that, although had the cornea had a loss of regularity. It also had reduced thickness. So if I'm not wrong, it was 480 micra here. And this image from Scheimpflug showing a bad D of 0.97. So normal, completely normal. And this is the fantastic high resolution image from the MS-39 that we could see. And then we performed, in this case, the OCT with MS-39. And our main purpose here was to check the epithelial map. And you can see here on the right corner, low, a completely normal epithelial map. Then now we had another parameter that we took also into account to reassure the patient that here that was probably not a keratoconus. So all the devices had the same answer. It's important just about the epithelial maps in OCT. Of course, it can be an additional tool to screen keratoconus, but it's just important to remember that screening is a method to identify the disease before it presents signs or any symptom or visual acuity changes. But this is not the same as diagnosis. So normally screening methods has a high negative predicted value. So when we see that it's normal, this would be probably the case. So that's why this case was that OCT with epithelial map was very helpful in this case. And finally, a curious case also regarding the use of epithelial map in keratoconus. So a patient with a topography, he had a very high asphericity, as you can see, minus 0.58 in Scheimpflug, and the bow tie was a bit truncated. There was a superior inferior around 1.5 diopters difference between the central area, and the patient had a completely abnormal bad D. So some would say that would be over 1.2 or 1.6, depending on the sensibility and the specificity. Here, the patient had 2.18, so completely abnormal. And also biomechanical parameters completely abnormal. So the patient had keratoconus from these devices. But then, from this perspective, I would say, but then with the epithelial thickness, we had a completely normal profile. This is the image from the patient. You can see the thickness very regular in the whole cornea. And just as an example, this is not the image from the patient, but in an advanced case of keratoconus, that's normally what, not necessarily advanced, but in keratoconus is that perspective we would see. So we can see the posterior flow changed, but also the epithelial changes. So the thinning on the apex of the cornea, as Dan Reisten described it as a Dunnet pattern. But here again, coming back to our patient, we did not find any of those patterns or signs in our patients. So the patient really had a normal epithelial map. So that case, especially after, if you, the other panelists could comment their option, their opinion on this case, because I would like to learn actually, but that's what we call a low K keratoconus. So it would be a keratoconus, but with low K. And the interesting point here, the patient had a normal epithelial map. So we believe this case would also not be progressive. So here I'm saying something that is not consensus, because we don't have studies to prove that so far, but maybe epithelial map in future can give us a tip, let's say, if a keratoconus would be progressive or not. We can speak a bit of this later, but we always wanted a tool to in one visit bring this answer. And of course, if the cornea is changing, the likelihood of having a epithelial change would be higher. But here specifically, so we classify this as a low K keratoconus with a normal epithelial map. And but this shows exactly how the new technologies do not always agree from our perspective that we have nowadays. And of course, we have a lot to learn on this, but for sure, the epithelial map and the whole evaluation that the OCT technology can bring us together with the posterior float add a lot of information for us in this case. So as a final messages, the epithelial map is an important additive tool for keratoconus screening. As I said, screening is different from diagnosis. And the combination of a high resolution OCT and Placido technology may help us in the management, such as complications. As I show you, this is particularly helpful as well post cross-linking, because due to light scattering, the OCT may be it is very helpful to evaluate corners that have a slight or strong opacity in cross-linking patients. They normally present a haze post-operatively, so the pachymetry is better assessed with OCT. So thank you very much for your attention.